Hi, Kim.
Hey, Dana, what up?
I made it with a minute to spare. Best day ever. As soon as I sit down, the sirens start. Coming to get me.
Are they coming to get you? Yeah, I was just gonna say, this could be the most entertaining meeting ever. You get hauled off the Zoom screen?
Exactly.
Yeah. All right. I'm watching. I'm gonna say I have no idea who you are. Never seen that man before in my life.
It's probably safer that way. All right, we'll give everybody one more minute and then we'll get rolling. Roger Austin is coming live from like Santa's workshop. That's an impressive tool array you got back there.
Thank you.
Now it's kind of want to go hang out in my workshop for a little while. Yours actually
Yeah,
looks organized and clean. Mine doesn't look that nice.
It may be the lazy way of doing woodworking because the tools where I can see them rather than trying to remember which toolbox it's in.
Mine are just under a pile of sawdust and just dig around for a while. Wherever I left it last. All right, it is 12:16. We're close to kind of cruising altitude, so I'm going to go ahead and get rolling. I don't have a ton today, but we always seem to fill the void, so we will go ahead and get rolling. So welcome, everybody. It's been a couple weeks. Hope everyone is doing well. The last 2 weeks have been somewhat indicative of what we've seen for this pandemic for a while. We kind of were on the downward slide. It had started to plateau a bit, and then now we're back on a little bit of an upward swing. Not in a surge swing necessarily, but there certainly is concern as this BA.2 Omicron subvariant, which is 30 to 40% more transmissible, at least at this point, does not seem to be associated with more severe disease, but certainly is more highly contagious, is now the predominant. It is 55% of all of the isolated strains in this region. And I think now in the country, it's roughly 55, 60%. So it has become the predominant strain across the US, but our region as well. So what does that mean? So we are starting to see, certainly in the younger, again, the unvaccinated, and even those who are older and only had the first 2 doses of immunization, that they are the ones who are presenting now with the disease. Thankfully, the vast majority are still in that mild kind of category. Certainly, we have a host of people just kind of surveying folks that we've been talking to that find out that they are a contact and then get tested and find out that they are positive. So there is still a large asymptomatic component to the group. What we have not seen, thankfully, at this point is a resurgence in hospitalization or mortality. The only exception, and this is more from national data than it seems to be for local data that I've seen so far, is there does seem to be a slight increase in mortality amongst the African-American community from COVID related deaths. Now that is interesting because we've seen this fairly rapidly decelerating course in mortality from COVID overall. Yesterday in the United States, there were 762 deaths. If you go back, it wasn't that many weeks ago that we were at the thousands of deaths a day plateau, even 10,000 plus deaths a day. So this is certainly a far improvement from where we were, but it does seem to be some, I guess I'll call it societal segregation now, where it is younger and communities of color that are seen to be more disproportionately affected. What I do not know yet from that data is, are these communities that also have lower levels of vaccination, or is this just fascinoma of this new subvariant? I don't think we know enough about that yet, but it's certainly something we're going to be watching for. We know from prior that there doesn't seem to be any racial difference as far as how the virus affects people or genetic subtypes that they're sensitive to, so to speak. So at least when we look across, especially with Delta and even the Alpha variant, where there was some genetic drift in the mutations, it did not seem that there was a racial difference in which mutations folks were more sensitive to. So, we're still pretty early. I know it's, we're 2 years in and it's getting harder and harder to say that, but some of this genetic susceptibility, we may not know for years to come, just until we get enough research and enough of a preponderance of data to show that. So it is something we have to keep an eye on, but it is intriguing both that there seems to be a higher rate of infection amongst the African-American community, but also a higher mortality rate when the rest of the group that is getting infected does not seem to have a higher mortality rate or hospitalization rate at this moment. So something we have to watch. The other big news in the last 24 hours is the FDA has now approved and recommended a second booster dose for those over 50 who are immunocompromised. There is the expectation that over 12 and immunocompromised may come next as far as a second booster dose recommendation. It is the current thought or plan that unless there is significant change or genetic drift in the variants, that there will not be a general fourth dose booster recommendation until fall for the general populace. So we're probably several months away from a fourth dose for all plan or recommendation. And I think that's probably twofold. Number one, we're not seeing the resurgence in hospitalization and mortality, even with this new subvariant. But number two, there is some concern or speculation as to whether we should have a more broad spectrum booster rather than just the same boosters we've had before. So as we get into that fall time period, knowing that it takes about 6 weeks to develop and have a booster ready to go, and then probably at least another couple weeks of approval thereafter. If we're going to see a new or broader array booster come available for the fall, we're probably going to be hearing about that going to FDA approval sometime by end of summer would be my expectation. So what happens in these next couple of months, if it follows the last couple of years, we would expect to see, just as the weather improves and people get outside more and they're less in confined areas, schools let out, that we should see a decrease in infection rates overall. And unless this new transmissibility of this more contagious subvariant changes that, the next couple of months should be a slightly calmer time period overall. So that's the current state of the union as far as the new variant and vaccination plans. As far as testing, there has been some conflicting information in the kind of popular press, I will say, about whether this BA.2 subvariant is easily or well detected by antigen testing. Now, remember, we've talked all along about antigen testing having a reduced sensitivity and specificity. There seemed to be some concern that in Omicron in particular, the antigen test may have lost some of their sensitivity and specificity. And there is some concern that the BA.2 subvariant, that is now the prevalent variant, may be even less likely to be picked up on antigen testing. I have not seen anything yet to firmly support or refute that claim. So I do think it's something we're going to have to kind of keep an eye on. We never really got a firm answer as to whether Omicron was really evading antigen testing. It was a concern. Remember, our community incidence rate had dropped to the point that if we backed up 2 years ago, we would have said antigen testing wouldn't have been a good choice because the risk of false positives and false negatives would have been high enough that we couldn't have trusted the antigen test sensitivity and specificity. We are not that much of an increase in incidence yet that we would be out of that kind of statistical realm where PCR would still not be the de facto source of truth at this moment. And thankfully, although there is still some supply chain issues for the Roche and the Cepheid machines, Even that, my understanding is a little bit better. And so there's not the shortages of that point of care PCR or of the more standard laboratory-based PCR testing that should not be relatively omnipresent for anyone who needs it. The next piece that has, I think one person emailed me, I've actually heard a couple that had patients that were interested in getting Paxlovid. And questions are really severalfold. Number one, is Evusheld readily available, and should moderate to high risk or patients who are coming in more sick with COVID be referred for Evusheld more readily? There is still a large shortage of that drug available. And as folks know, sotrovimab was just pulled back recently. So as far as the monoclonal options, that really remains unlikely at the moment, I would say. As far as Paxlovid, the oral antiviral therapy that is somewhat available, it is still in relatively short supply in the local pharmacies. I can just say from the couple of folks who have reached out to me asking if I had any insight as to which pharmacies may be stocking Paxlovid. The website that NewYorkState.gov is advertising is not always accurate. There is a lag in that information. So pharmacies that supposedly have a supply on hand, I'm hearing kind of secondhand that when people go to that pharmacy, they've been out for at least 24, 48 hours, if not more in some cases. So I would say that is a good starting point. But if you're feeling so inclined as to prescribe that to a patient, I would say it is probably worth a call to that pharmacy before you start the wild goose chase, because it may in fact be that they do not have a supply on hand that they could dispense. So the final question that folks have asked is, okay, this is kind of a pain chasing where Paxlovid is available. Is it even worth it? Do we even know if it works on the BA.2 subvariant? I do not know that at this moment. From what I understand about how the drug works, there's no reason to think that it would not work for that subvariant. And it certainly was more effective than the Mupiravir, or what it was, the alternative, that is also even less available now, as I understand it. But I do not have any reason to believe that Paxlovid would not work as well. But remember, it was really just to avoid hospitalization and hopefully shorten the course of illness. It was not to completely rid people of having any symptoms whatsoever. And it ideally should be given within that first 5 days after onset of symptoms begin. So if you're outside of that, or if you're a low risk individual, I would say it's probably not worth taking the supply away from those who may need it. If you do fall into the category, or if you have a patient that falls into the category of high risk and or moderate or worse symptoms, then it probably is worth a little bit of phone tag to see if someone has it on hand, because the website may not be the all-knowing at this moment. Other than that, I don't think there's a whole lot else new from my end of the world. We're from a state standpoint, there has been lots of discussion about further unwinding of the state of emergency. That will come due on April 15th. There has been some discussion about partially unwinding that, although I don't know what that would actually look like, and we haven't gotten a lot of details about what a partial unwinding of the state of emergency may invoke. There is still significant concern that January and February were the 2 worst months on record financially for hospitals. And that happened just at the time where provider relief funds have started to run dry. And that same cost effects is drifting out into the practice space as well. So one of the questions is, would there be another round of provider relief funding? With the culture right now and where we are with inflation and the economy, there's a big concern. I don't know that realistically another round of PRF funding could get passed through Congress at this moment, even if there would be enough support amongst the Democratic caucus to get that passed at the moment. So there has been some discussion about reallocation of other funds, but that really means robbing one hand to feed another at the end of the day. And we have already seen that in some of those cases, those funds come out of pools that were needed in other elements of the pandemic response or public health response in general. So it's not necessarily a get out of jail free card just to repurpose those funds. So for right now, I am not aware of any new PRS programs, even though we might be in a position where on the whole, the healthcare economy is more in need of it than it even was when the last round was dispersed. But I think, it's going to stand to take some time to see where things shake out over the next coming months. But I do know the hospitals in particular across the country are, if they were vulnerable, they are even more vulnerable now, which is certainly something everybody is attentive to say the least. So beyond that, I think the state of emergency will stay into effect until mid-April. Many folks have raised questions. We've talked about it here before about what this will mean for telehealth. It's an interesting discussion. As we've talked about here, we have gotten multiple reassurances that our local payers understand that telehealth is now kind of part of the healthcare ecosystem, that they could not and would not pull the rug out from under it, that they may begin to roll back parity for things where telehealth would not be the ideal way to engage the patient, i.e. new patient consults, new patient visits, that kind of thing. But we have heard, or at least I have heard, no change for now. And historically, we've been told we would be given at least, and I've heard 60 to 90 days kind of interchangeably, warning that once the state of emergency ended, they would give us at least that time period of warning before they would make any changes in reimbursement or coverage. The interesting point of that conversation is there was just a large paper put out by, I think it was Main Street USA, one of these kind of healthcare consortiums, that basically said telehealth is dead. That for all the talk and all the pomp and circumstance, that there is now a backlash, and that when you survey patient populations across the country and some of those vulnerable populations, like rural, like inner city, that there is actually a disenfranchisement of patient populations with telehealth. Now, I don't think we have seen that here. That has not been my experience or what I'm hearing from providers or patients that I encounter. In fact, I quite hear the opposite. But it was interesting that a large, generally forward-thinking group would make such a kind of bold statement that telehealth may be on its deathbed before it really even got up and crawling to some extent. So just something we'll have to be on the lookout for. Certainly I think patients have come to value that face-to-face interaction with their provider, maybe now more than ever before. And so I certainly think that there's probably a component of that at play, but I just don't see how in knowing that we are facing a time where providers are going to be at a shortage, that we're going to see an acceleration of planned retirements over the next 5 years, and we will likely have a nationwide shortage of at least 20 to 30%, if not more, of healthcare providers. I don't know how we will be able to meet the healthcare needs of the community if we do not have telehealth as a viable resource. So it may be a necessity, even if it's not a desirability factor. So put that out there. I have not heard that having any implications on considerations for reimbursement right now, but it's just an interesting counterpoint of discussion that is out there on the table at the moment. Okay, I think I have talked enough. So I will shut up and I will hand it to LJ and I will go on mute.
Chad, before you mute, there's a question in the chat that you could answer because it's relevant. Does the mask mandate in hospitals and clinics end on April 15th if the state of emergency ends?
No. So everything that we have heard and everything that we have talked about and intended is that masking in hospitals, even if the state of emergency will end, will fall under the directives of the Department of Health. And at this point, there is still a very strong feeling that masking, at least in clinical areas in the hospital, will likely be an enduring factor for some time, if not permanently, for the time being. So I don't know that we have any plans to roll that back. I think in non-clinical areas, meeting spaces of the hospital, we're already starting to see some rollback of that. But I can tell you that has even had a little bit of a slowing effect as this subvariant has grown, because people are worried that what that would do with staffing models if we start having grand rounds and staff meetings that are unmasked, and then people get exposed, and then we have less people available to actually take care of the patient population. So I think we're seeing a little bit of a pause on unmasking, even in non-clinical spaces within hospitals. So no end to masking in the hospitals anytime soon.
Thanks, Jen.
There you go.
So I just have a couple of very quick things. I wanted to highlight a question that came up from one of our primary care providers, Dave Topa. And this is a question that's being reiterated by pediatricians and family physicians caring for kids around the community, and it relates to the lack of sort of protocols or guidance now around what forms of testing to use and for kids who are symptomatic with COVID symptoms and are using negative testing to come back to school. So seeing a number of families whose kids develop a cold or other symptoms, but test negative at home on day 1, and then are sent back into school. And then they actually go on to test positive at day 3 or 4. And, this relates back to Chad's comments about, timing of testing, right? But also, is the antigen test adequate? We don't, I'm not even going to go in that space, but this is something that is happening on a more repeated basis. In light of the fact that we know that there's nothing new, I did confirm this with local county health department directors today. There's nothing new that's coming from the state. There's no anticipation that there's going to be a change in the masking requirements in schools or otherwise at this stage just yet. And there will not be local health department guidance coming out in that space either. Dr. Topa raised the question is it a reasonable thing for at least us in the healthcare space who may be consulted here to encourage that those kids are going back to school with a mask on, and that then they, then they test again later if their symptoms are persistent. And Dave, I think that it makes a ton of sense. It makes a ton of sense to mask if you're still symptomatic and you've only tested in the beginning. And I think recommending a follow-up test day 3 to 4 for those kids that are still having symptoms, yes. And I also think it makes a lot of sense for kids who are close contact exposure to wear a mask when they're going back into school. And then there's a recommendation for them to test as well. All we can do, I think, is say what we think is in the best interest of that patient and the community of the kids that they are in. The difficult thing in this space is, and I feel like I just got confirmation on it on my phone, there is not going to be specific guidance changes that are going to back that up. And in the schools, it is a language of recommended as opposed to required. And so I think, yes, give your best clinical judgment and recommendations. And I think those are very reasonable. And I think if we're doing that collectively as a community, it may have some influence, but at the same time, I can say as the parent of a child in high school for whom we have now received several notices that there was a close contact in school. And I say, so are all of you in your class masking? And the look I get is like, no, that's in a household where we're like pretty strict and stuff. So I think do the best that we can. We need to keep monitoring and see what's happening. And hopefully what Chad said is true. Hopefully this will be a little blip and not a big, surge again. But we're still in the same space we were before. Many people have reached out to ask if there's going to be new guidance set by the county around what are the conditions for which need to be tested for. There's nothing new. There's not anything coming. It is going to be the same protocols for symptoms, the same recommendations at this point for testing. And then I think likely, unless something significantly changes in our community, it's going to look like this right through the end of the school year. So I just wanted for people to know that. And if anything changes, we promise you will be the first to know as soon as we do it. We'll get out a messaging so that you're all aware. And the other thing I just wanted to mention is speaking about COVID vaccination and highlighting again, because I want to do a nice handoff to Jana. You're aware that Moderna has requested FDA review of their vaccine for the 6-month-olds and up. And this is exciting. And the date is actually scheduled for that review. It is April 6th, if you weren't aware of that. But that is when the FDA board when that is going to be reviewed by the vaccine review board. So if things follow, we know that they may be looking at Pfizer also, but it's not clear that that's on the agenda yet, but Moderna is. If things do follow the way they had previously before the last review for Pfizer for the littles, we could be looking at vaccination by third week of May or third week of April, excuse me, I would think by mid to third week. So for all of you who are ready and already doing vaccines or who are standing up vaccinations for the younger kids now, your responses have been amazing in that space. And I just want to highlight for you, if you're getting your vaccine from the county or from a hospital, if you're a hospital-based practice, from a hospital pharmacy, it would be really good to let those teams know that you're planning to vaccinate, because they will, who knows where this will go, but if they put in an order, you want to be sure that they're putting in an order that includes your practice. Jana, do you have other things? That's really it for me. So Jana, I don't know if you have anything else you wanted to talk about in that space.
Yes, and along those lines, actually, there was just some new guidance that came out from the health department around reallocation, some changes to transportation of COVID-19 vaccines. So those are up on our website, and they'll go out and then the update after this meeting today. As LJ mentioned, we've reached out to some of the providers who have not, been able to start vaccinating in the office for whatever reason, just to offer support and any resources that we can. So if you are still feeling like you would like some additional resources, you are more than welcome to reach out to myself or LJ, and we'd be happy to, have those discussions. And then the toolkit is also up on the website. If you don't feel like you need to have a full-blown conversation with us, that resource is available, and we can put that out there again as well. But those were the only two things that I had to mention: transportation of COVID-19 and then the toolkit. So that's all I got.
Renee, anything from your side of the fence?
Yeah, I would just note that I have been received from some claims examples from practices who are experiencing claim denials for COVID testing. We're happy to follow up with Excelis to see what's going on there. I do ask if you have some examples to send, please let me know first before you just send them, so I can send you a secure email that you can respond to. We really shouldn't be sending PHI just over the internet randomly an email. We really need to use a secure email. So if you have anything you want to share with me, let me know, and I will send you a secure email that can be responded to, and then you can send me those claims examples. Claims examples have to include the code that you billed, first name, last name of patient, patient date of birth, and date of service that was denied. So please feel free to reach out to me if you need any assistance with that. And that is it for me.
Perfect. All right, the chat room is empty. Any questions anybody else has? Concerns, words of wisdom, interpretive song? All right. So for now, let's plan on keeping the follow-up in 2 weeks as we have been. If the world goes silent, if everybody's on spring break and nobody wants to talk, we can certainly cancel as we get closer. But just not knowing where things may go in the coming days or weeks, it may be worth it if we have a new vaccine for consideration, if we see a surge from BA.2, if there's something else that comes about. So we'll keep it for now, and then we'll kind of repurpose depending on where the world looks over the course of the next 14 days. And always, if something exciting happens sooner, we will reach out electronically and reconvene if we feel like it merits aggravating you sooner, face to face. But for that, we will leave you alone. Have a wonderful couple weeks, and we will see you guys soon.
LJ,
Care,
Chad,
everybody.
Renee, can you guys hang back for a second?
Yeah.
Why did I get made to stay after class? I didn't do anything.
I've actually
You're-
found that it's just a lot easier to talk about the newsletter while I have you guys here. as
Perfect.
opposed to an email. So,
You're not in trouble. They didn't come arrest you. You're not in the principal's
Well,
office.
just because they haven't barged in yet, I've got the door locked. So
as if they'd be so polite to wait until they hear you're not on a call anymore.
they might. You never know. It's Dansville. There's a degree of decorum down here.
It's gonna help some of these folks.
Do you want to stop recording, Jana? So you don't
Oh
have
yeah,
to.
that would be helpful.